Now we have something special. We're going to hear about survivorship and patient support from two outstanding nurse practitioners. They are quite a pair. I've worked in 4 different institutions in my career. I've worked with some incredible nurse practitioners, but these guys are the best. Kathy and Rajni are going to now talk to you, and I guess you're going to tag team it. I think it's a great idea, and it just fits in with the flow of how we all work together. So, Rajni and Kathy, Kathleen Madden and Rajni Kannan.
Okay, as Dr. Weber just said, I'm Rajni Kannan, this is Kathy Madden, and we are partners in crimes, many crimes. We do a lot together, but we also work very closely together with the docs in managing patients. So we're going to talk a little bit about some of the stuff that we're involved in, some of the, hopefully soon, trials that we'll be running as nurses. So the term cancer survivor, it's a unique term, and there's a lot of definitions out there, but the definition that's really being used out there is anybody who has a history of cancer, and it's starting from the time of diagnosis, not just the time of when they complete treatment. So anyone who's had a cancer, whether it's an early melanoma, an early squamous cell, they're still considered to be a survivor. So 1.2 million melanoma survivors are living in the US as of January of 2016, and there are additional melanoma patients being diagnosed every day. So what does it mean? Melanoma survivorship, pretty much in early melanomas, is very, very long-term survival. So they're usually 92 to 89%. And about 84% of these melanomas are diagnosed at local stages, for which the 5-year survival rate is amazing. It's 98%. It's those patients with advanced disease who are now starting to talk about that term, survivorship. And it's new to melanoma. There's not a lot of information out there. You hear about all these breast cancer survivorship clinics and studies that have been done. Well, melanoma has been lacking in that because we're just talking about the C word that Dr. Weber and Dr. Pavlik and Dr. Wilson have been talking about today. So depending on the size and location of melanoma, surgeries can be disfiguring, and that's one of the concerns in some of our melanoma survivorship patients, especially the early patients. With a lymph node dissection, as Dr. Shapiro said, there is a risk for lymphedema, and that can cause interference with activities of daily life. And that's one of the biggest concerns in our patients and survivors is, how is this going to affect my future? How is it going to affect if I'm a carpenter, if I've got lymphedema of my arm? Can I still do what I did prior to my surgery? So survivors of melanoma are more likely than the general population to have additional melanomas due to their skin type, other genetic risk factors, and overexposure already to UV light. Health maintenance is really important in these patients for secondary cancers. They need to have normal health maintenance. And the question is, who and how do we do that? So advanced melanoma patients is kind of where our research is going to be taking us now. We need to see what are the needs of survivorship in these patients. So hopefully coming to a clinical trial near you will be a look at patients who have gone through immunotherapies and targeted therapies who are now greater than 5 years out, and what are their concerns? What are their issues? And we're learning from some of our patients who didn't know they'd be alive. We have one patient of ours who sold everything she ever had, dropped her Wall Street job, took every class she ever wanted to take. She took an architecture class, an art class, she took a language class, nothing to actually get a degree, but just classes that she always wanted to take. Well, now she's alive. And she has no 401k anymore. She doesn't have a job. And what does she do? She moves back in with her parents. So she moves to Montana, lives with her parents. Now she has to find a new oncologist. And now she's living on a farm with a new fiance. And she's running a farm. This is her new life. So life has changed dramatically from this 27-year-old who was a Wall Street, big, making money person. But differences come with how do you survive when you have melanoma. And we're hearing these stories over and over again. We have a teacher recently who now is starting a healthy bakery. She's been a teacher for years. She's going to give up teaching. And now she's going to start a healthy bakery, because this has changed her so much, this living with melanoma. So the questions we need to look at: how long should these therapies be continued in patients who have stable disease or no evidence of disease? That's a question still being answered. Do we stop? How often do we watch them? Who watches them? And we want to know, what are the later side effects, and how are they associated both physically and emotionally? We have one patient of ours who got one of the first clinical trials with an immunotherapy, who still says that she knows where every bathroom is on a highway just in case the diarrhea develops. And she's 12 years out, but it does show up still. So she needs to know where those bathrooms are. And it's amazing to us. We have patients who are out who are on hydrocortisone supplements for their adrenal issues. If they don't take it on an airplane and they're on vacation, they're going to pass out somewhere. So they have to remember to pack their meds. But these are things that when you're going on vacation, you want to go relax. You don't want to remember that medicine you have to take every day. So these are some of the concerns that we're learning as we go now that we're dealing with survivorship. And the health maintenance for secondary cancers, heart disease, and other illnesses. We used to tell them, oh, well, you don't take your statin medicine for your cardiac issues. It's all right, because we didn't know they were going to be alive. Now, we can't stop these cardiac meds. We need them to get those tests that they should be getting. Stress tests were being ignored. We were ignoring dermatology visits, even though they were at higher risk for secondary melanomas, because we didn't know if they were going to be alive for them. So we need to start figuring out who's responsible. Because a lot of these patients, especially here at NYU, come to us from far away. Far away may be Jersey, far away may be another country. And so therefore, who's going to manage this now? Who's going to make sure their side effects are not related to their therapies? Who's going to make sure that these side effects are not related to something as simple as they left the country and got a GI virus? So that's where we're trying to figure out what does survivorship mean in our patients and where do we go with it? So hopefully Kathy and I will be starting, like I said, in a clinical trial coming near you, a look back on our patients and then eventually a trial going forward with our patients of how do we decide what's important in melanoma survivorship. So Kat's going to talk a little bit about what happens when these survivors are living and what services we have during and after they've completed treatment.
Thanks, buddy. Hi, everyone. Thank you all for being here, and thank you to everybody who's with us in spirit online. So supportive services, this is really come to a new generation in and of its own right now. If we look back into the early 1700s, the time of Rene Descartes being the modern day father of medicine, and the concept of dualism really came from a separation of religion and medicine really in its early roots. And at that point in time, there was a lot of politicism that went along with that. And there was a division of body and mind and spirit, if you will. So that really did silo the origins of our modern day medicine concepts and constructs and how we delivered care to our patients. But I'm glad to say that we're in the time and age where we recognize that people are not siloed, that they're not separate, that the body, mind, and spirit are all one and interconnected, and that we need to address our patients and do them the full service that they are one whole being. And that being changes and shifts, and their needs shift and change. And what's nice is that we do have opportunities, not just at our cancer center, but at all major cancer centers, opportunities and services for patients such as psychiatry, support social work, which offer counseling, and the whole lineage of services below that, home care referrals for visiting nursing services, equipment services, hospice care when needed, transportation services, a huge thing that we have to think of. We think of a metropolitan area here like New York City, and we have so much transportation, but yet it still tends to be an issue for a lot of our patients, especially if they have disabilities or there are aspects of their cancer which are causing them mobility problems. Insurance conflicts, I'm sure nobody knows about that. But there can sometimes be some real issues, and we need help with that, and our supportive services department can help. Support groups are a tremendous asset for our patients. They can be hospital-based or they can be community-based, such as one like Gilda's Club, which Rajni and I have aligned ourselves with. They've invited us to come and do some community support work with them. Nutrition services is a huge opportunity for our patients. We not only capture our patients who are receiving active treatment, but we also capture our patients who are completed treatment. So at any point in the journey, these services are available. Some additional support programs are chaplaincy services, smoking cessation programs. As Rajni pointed out, our patients are not only living with their cancer, but they're living with the cure of their cancer as well. And it's so impactful to continue healthy lifestyle habits that either they pick up during their cancer journey or after their cancer journey. The music therapy program has been very instrumental for a lot of our patients. And the pet therapy program, if you'll see the picture in the lower corner, not only do the patients enjoy Newton coming to visit us, but so do the clinicians. Legal services. We're very fortunate to have NLAG, which is the New York Lawyers Association group, which is a pro bono organization. They offer their services pro bono to us. We have a contract with them, and we're very privileged. They have helped so many of our patients from very simple legal issues, such as a disability dispute, all the way to custody issues. So we understand that our patients are not siloed just because they're cancer and that's the only experience that they have. Our patients are whole body people that have responsibilities. So Carol Cutts provided us with the permission to show her image and a little bit of her story. Carol is a cancer survivor. She's been with us for 4 years. She tells her story of the fact that I wanted to point out that the adult recreation and creative arts. She was outside of a church service a few weeks after receiving her diagnosis. And she had gone through, was still in the phases and stages of being angry and crying and very frustrated and very upset and a lot of questions. And a friend of hers said, "Why don't you join me in a 61-day challenge on Facebook?" And it's called the Yellow Day Art Project. And essentially they use index cards once a day and do a drawing. It's just on index size. She said, "I don't know how to draw." She goes, "It doesn't matter. Just give it a go." And within 6 days, Carol was expressing her passions out onto paper, and this is one of her creations that she's made. Within 6 days, she had stopped crying and had an avenue for her to channel her creativity and her anger and her frustration and begin her healing journey of acceptance and coping with her cancer. So one of the things, and I'll have Rajni join me with this, is healthcare proxy. I want to point out legal services helps with this, but you don't need legal services to help oversee this. These are important documents that not just with our discussion with survivorship, but we encourage everyone. You don't have to have a healthcare diagnosis or issue to have one of these. That, we take a lot of responsibilities and we make a lot of choices in our life, like, what kind of car we want to buy, where we want to live. But a lot of times there are some missed discussions on how do we want our healthcare conducted if in the opportunity that we aren't aware to make our decisions for ourselves. I'm sorry, I'm bumbling my words there. But if we lose capacity to speak for ourselves, who would we want to appoint to make those decisions for us that we trust? And
NYU's actually started a new service recently, and it's really it's up and coming. You're going to start seeing more of it, especially at these survivorship clinics. And the fact is, we live in New York City. Unfortunately, people get hit by buses. People get in car accidents. Taxi drivers run you over, which is not a good thing in this city. But you need to have a place of who's going to make decisions for you if you're not able to. So there's actually Dr. Glassman, who is our VP of Nursing, has started a new initiative, and it's called First Steps. And it's from a very researched program. And what First Steps is offering is an ability for you to come speak to not your provider, because your provider may actually have you. It's not a time to ask cancer questions or about your diagnosis, but it's a time to have somebody who's non-associated with your diagnosis. Or if you're a healthy person and just had a recent melanoma resected and it's an early stage, but you think, you know what, I really need to have this in writing. There are clinicians as well as nurses as well as social workers who are trained in this First Steps program to help a patient write out what their advanced directives should be. And there is one actually going to be starting as well for end-of-life decisions as well for those patients who are maybe not responding to treatment. So what's great is this is a new initiative by NYU, and our goal is to be what Gunderson, which is in the middle of nowhere, they have 89% of their people, residents over the age of 18 have healthcare proxies. So if you go to the hospital, it's actually on file. So our goal is to have healthcare proxies at that level here at NYU. And it doesn't matter if you're in a surgery, if you're doing cardiology, but we want to do it universally. So if you're interested in first steps or have any questions, let me know, because I'm one of the first steps trained providers. So
thank you. And I just was looking at the forms last night. I was like, well, where do you locate these forms? I got my first forms at Staples way back when, like 20 plus years ago. But you can just go on Google and Google healthcare proxy forms. Just know that they are different state to state. So if you're here a resident in New York, choose the New York forms. Take a look at it. There's actually more information than there are forms to fill out. There's about 8 pages, but actually only 2 pages that you need to fill out. So just to kind of wrap up, Integrative Services is a huge complement to our supportive care services. Although there's limited data, there is a growing body of data, but there's still limited data on how to incorporate integrative services into cancer care and into medical surgical care. But more and more cancer patients are utilizing these services. So the National Cancer for Integrative Health and other organizations and foundations do fund and support advancement in the research and education. And things that are offered here are acupuncture, massage, Reiki, yoga, counseling, not only to the patients but also to caregivers, relaxation techniques, and not only for the patients and their caregivers, but also the staff too. So it does take a village to care for our community of patients, and you can see that it's one concentric circle, that it never stops. It's fluid, it's continuous, and it's all-encompassing. So thank you, and next up is our patient to tell his story.